Next, I call Harini, outcomes and clinical profile of collapsing glomerulonephropathy in renal allografts.
Good morning, everyone. I am Dr. Harini from Madras Medical College. I will take this opportunity to tell about my study on clinical profile and outcomes of collapsing glomerulopathy in renal allograft recipients. So, collapsing glomerulopathy is the retraction of glomerular basement membrane causing occlusion of capillaries and associated with podocyte hypertrophy and hyperplasia. So, the cardinal manifestation of collapsing glomerulopathy are worsening serum creatinine, severe nephrotic syndrome, and a poor response to routine immunosuppression. So it has multiple etiologies. As we all know, it has multiple etiologies like infections, autoimmune disorders, drugs, and other genetic causes. So in the affected podocyte, we can see the loss of maturation markers and there will be increase in the proliferation markers. So this podocyte will behave like a macrophage and this is known as transdifferentiation. So this is an image taken from our one of our allograft biopsies. Here we can see the collapse of the capillaries, collapse of the basement membrane with the occlusion of the capillaries. And also in this patient, we can see the fibrin thrombi occluding the capillaries. This is actually a case of collapsing glomerulopathy with associated thrombotic microangiopathy. So the aim of our study is to analyze the clinical profile and outcomes of collapsing glomerulopathy in renal allografts. It is a single center retrospective study done at Institute of Nephrology, Madras Medical College from January 2011 to December 2022. In this study, we have done a retrospective analysis of renal allograft recipients whose biopsies revealed collapsing glomerulopathy between 2011 to 2022. Here, we have analyzed the demographic data, clinical profile, transplant-related data, immunosuppressive regimen, graft function, viral markers like HIV, hepatitis B and C, cytomegalovirus, BK virus, parvovirus, renal allograft biopsy data, and outcome of the patients. So coming to the results, out of all the renal allograft biopsies done, we had 15 patients of collapsing glomerulopathy in renal allografts. Among the 15 patients, 5 patients had lost to follow-up. So we have analyzed the data of the rest of the 10 patients. In our study, all the 10 patients are males.
Slides are not moving, sorry.
In our study, all the 10 patients are males. So it supports the fact that collapsing glomerulopathy is more common in males. So in our study, the mean average age is 30.1 years, ranging from 19 years to 40 years. The mean age was 30.1 years. And the prior dialysis vintage had an average of 15.4 months. So in our study, around 8 patients had not known, the native kidney disease of that 8 patients were not known, and 2 patients had biopsy proven IgA nephropathy. 7 patients underwent live related renal transplant and 3 patients had cadaver transplants. Among the 10 patients, 6 had no induction regimen and 4 were given basiliximab induction. And all our patients were in standard triple drug immunosuppression, among which 6 had tacrolimus and 4 had cyclosporine A. So none of our patients presented only with nephrotic syndrome. All our patients had allograft dysfunction with the creatinine ranging from 1.8 to 12 with a mean creatinine of 5 milligram per deciliter. The proteinuria also varied from nil proteinuria to 4 plus and with a median of 3 plus. The nil proteinuria in one patient could be due to a lead time bias. So coming to the timeline of occurrence of collapsing glomerulopathy, 3 of our patients had occurrence of collapsing glomerulopathy in less than a month. And mostly all other patients had occurrence of collapsing glomerulopathy after 2 or 3 years. So the average duration is 877 days, which accounts for around almost 29 months. So in the biopsy, only collapsing glomerulopathy was seen in 7 patients, and it was associated with focal segmental glomerulosclerosis, IgA nephropathy, and TMA in other 3 patients. So this is the biopsy data of all the 10 patients. Also, when we look at the number of collapsed glomeruli and the globally sclerosed glomeruli, we can find an inverse relationship because it gives an insight that collapse might be an initial event leading to the global sclerosis, which is the final outcome. C4D was almost is negative in all our patients, And in one IgA nephropathy proven case, he had a IgA deposition in the mesangium, and another one patient had non-specific IgA deposition. So coming to the IFTA, 4 patients had no IFTA, and the other patients IFTA ranged from 5% to 40%. 5 of our patients had associated acute cell-mediated rejection, and 1 patient had suspected CNA toxicity. He presented with TMA. So coming to the analysis of viral markers, only 1 patient had a CMV, cytomegalovirus positivity, and all other viral markers were negative in other patients. So coming to the outcome of our study, almost all the 10 patients had chronic allograft dysfunction, among which 4 patients were dialysis dependent and 6 patients were dialysis independent. When we compare our study with similar studies done in India and US, we can see the mean average age is similar in both the Indian studies, and we can see early occurrence of collapsing glomerulopathy and increase in serum creatinine and increase in associated with rejection in in the studies which were done in the later part of the decade, and the outcome was poor in all the studies. So coming to the limitation of my study, APOL1, HLA-DR4, HLA-B44 analysis, which are the known high-risk genotypes, could not be done for the donors and the recipients. And since most of the patients' native kidney disease were not known, we were not able to conclude whether the collapsing glomerulopathy is a de novo one or a recurrent one. And also the made kidney analysis of the cadaver transplant were also not done. So, and then comparison with native kidney collapsing glomerulopathy were also not done, and we were not able to obtain a difference in the clinical profile by comparing the both. So the conclusions of our study are, in all our patients, collapsing glomerulopathy had uniformly poor outcomes. At present, only 4 people are alive. Among the 4 patients, 2 are dialysis dependent and the other 2 had chronic allograft dysfunction. So in most of the cases, the etiology of collapsing glomerulopathy could not be ascertained. Thank you.
You're talking about only the outcome because of collapsing glomerulopathy.
Yes, ma'am.
But in your biopsy, if you can show that slides, you have many of them have rejection also in the biopsy. What have you done about that?
We have treated accordingly, ma'am. We have given steroid for those 5 patients, and for the patient, 1 patient with FSGS and the other patient with the TMA, we have done plex, ma'am. But the outcome was uniformly poor in all the patients. Everybody landed up with chronic allograft dysfunction, ma'am.
Okay. One more point that we notice, see, your average time to detection is 29 months.
Yes,
correct? And your IgA nephropathy already has 10 to 20% IFTA in that.
Yes, ma'am.
That's you must have reduced the dose for the one who had CNI toxicity.
Yes, ma'am. It was
correct?
reduced then. During the biopsy, there was cytoplasmic vacuoles in the proximal tubular epithelial cells. So CNS toxicity was suspected, and we have proceeded with the tacro levels, and we have reduced the tacro levels, ma'am.
Okay. That was good one.
Thank you.